Hello, my name is John Burke from Rocky Mountain Cancer Centers in Denver area. I'm a hematologist and oncologist, and I'm co-editor-in-chief of Targeted Therapies in Oncology. Talking today about a column I wrote about increasing role for minimal residual disease, or MRD testing, in hematological malignancies, specifically chronic lymphocytic leukemia and multiple myeloma. There were two papers published in the New England Journal of Medicine recently, and these studies were also presented at some of the summer meetings. And I think they demonstrate important findings that could be practice changing or certainly practice affecting. And so I'll review both of those studies. Just by way of background, MRD testing has been available for a while in these diseases. I think some of us have used it more than others. I think one of the sort of barriers to routine utilization of MRD testing has been the fact that it's mostly prognostic. That is, it can tell you the patient's likelihood of staying in remission for a longer period of time, but it doesn't necessarily tell you to change treatment for that individual patient. And so I think the criticism that's been leveled at it, and the reason that many people don't use it that often, is that it hasn't been practice affecting so much. And I think these two studies may be changing that a little bit. So the first in multiple myeloma was called the MIDAS trial. And in the MIDAS trial, patients were treated with 6 cycles of an induction regimen consisting of a quad, that is with isatuximab, carfilzomib, lenalidomide, and dexamethasone. And then patients underwent MRD testing after that. If they had undetectable MRD at 10 to the minus 5 sensitivity, then they were randomly assigned to get one of two groups, one of two treatments. So the control arm, the standard therapy, was to get high-dose melphalan plus autologous stem cell transplant, followed by 2 more cycles of the quad. And then the investigational arm was to skip the transplant and just do 6 more cycles of the quad. And the primary endpoint was MRD negative status after all that treatment at 10 to the minus 6 sensitivity, looking at basically, did you deepen the depth, the remission, the MRD remission status with that therapy. And so what was reported is that the rate of undetectable MRD at 10 to the minus 6 sensitivity was basically the same in the two groups. It was about 84 to 86%, basically, both groups had undetectable MRD at 10 to the minus 6 sensitivity. So I think the take-home point here is that in patients who achieve a good response to induction therapy and induction quad, and that was defined as undetectable MRD at 10 to the minus 5 sensitivity, the rate of achieving undetectable MRD at 10 to the minus 6 sensitivity was the same if they skipped the transplant and just got an additional 6 cycles of the quad, as opposed to getting the transplant. So it raises the possibility that perhaps in these patients who do well with quad, stem cell transplant could be eliminated. Now, caveat here is that we don't have long-term follow-up, so we don't have progression-free survival endpoints. So we can't say based on the PFS endpoint that the two strategies are the same, but certainly from the MRD endpoint, it looks like those two strategies are similar. So I think this could be practice affecting if it may lead many of us to start using MRD endpoints more commonly, and to try to select stem cell transplants, perhaps for those patients who don't achieve that undetectable MRD, but to skip it in those who do. So that was one important trial. The other important trial was in chronic lymphocytic leukemia. This was the FLAIR trial. And the FLAIR trial was a bit of a complex design, but basically it had 3 arms. It had a chemo arm with FCR, that is fludarabine, cyclophosphamide, and rituximab. It had an ibrutinib alone arm, and it had an ibrutinib venetoclax arm. The doublet therapy duration was driven by MRD status. That is, the length of therapy that patients received was double the time that it took them to get to undetectable MRD. So, for example, if it took the patient 1 year to get to undetectable MRD, then the length of therapy would be 2 years. And if it took the patients 2 years to get to undetectable MRD, then the length of the doublet therapy was 4 years. The minimum duration was 2 years and the maximum 6 years of the doublet therapy. The results of the trial were that the MRD-driven doublet therapy led to better progression-free survival and better overall survival compared not only with chemoimmunotherapy, but also with single-agent ibrutinib. And so, to my knowledge, this is the first time that any treatment at all has improved survival compared with a single-agent ibrutinib or any BTK inhibitor. So it's interesting, and it's a little tough to know, was the survival improvement a result of the fact that they used a doublet, or was it a result of the fact that they used MRD-driven therapy along with that doublet? There are really two variables, and we can't say which of those two is more important, but certainly it does suggest that MRD-driven duration of therapy with a doublet can improve outcomes compared with just single-agent BTK inhibitor. So I think that is another perhaps practice-changing trial with lots of open unanswered questions still remaining, but it really is a signal that MRD test could be used to drive duration of therapy and thereby improve outcomes for patients with CLL. So 2 trials, both of which are demonstrating that MRD can affect practice in hematological malignancies, and I think we're moving toward more use of that strategy in our patients.